Thank you to the organisers for inviting me. It's been a wonderful 2 days. I'm really glad that the most important topic, which is adolescence, always comes last. Those are my disclosures, but probably my biggest disclosure is that I am absolutely passionate about adolescents and young people. They are so much more fulfilling than young children or old people like us. Okay. I am really aware that for most of this audience, the numbers of adolescents and young people living in high-income settings is very small, okay? But what I really hope is that some of our shared experience allows you not to make the mistakes that we made 20 years ago, and particularly looking at the perinatal cohort. The oldest young people I look after who were born with HIV are now in their 5th decade. So they are in their early 40s. Okay, we made loads of mistakes. We learnt from young people along the way. We haven't got it all correct. And when we're looking at high-income settings, I think it's really important to think of it in 2 groups. I put the European group. Now, I have chosen to identify as a European. I live in London. Somebody told me we Brexited, but I certainly didn't. Now, Jason has allowed me to put Canada in Europe. Just for the next 8 minutes. Okay? But the groups are very different. Okay? So in our European cohorts, we tend to transition at 18. The majority have perinatally acquired HIV, many of whom are born in sub-Saharan Africa and migrate into Europe. We heard from Uli about migration earlier. Compared to my colleagues from the States over there, who have proper adolescent and young person care, they run combined use services and see a large number of young people who are infected later in their adolescence, but not at birth. And I have to say, when I'm talking with my adult colleagues, if you have lived with HIV for 20 years, you are seen as, a long-term survivor, as part of an aging population. But yet, when we compare the adolescents, if you think of somebody who has acquired HIV from birth who is now 20, compared to a young person who acquires HIV at the end of adolescent maturity in their 20s, by the time you reach 40, one young person has lived with HIV and/or ART for 40 years. Throughout all of postnatal and adolescent development. And the other young person has acquired HIV in their late teens, but has only lived with HIV and ART exposure for 50% of the time. So there are lots of similarities, but I'd go same, and different. And that is my plea. You're probably all utterly bored of me asking people questions going, is that data disaggregated by route of transmission? It's really important. And that's particularly important when we're now looking at the 3rd generation. So many of the wonderful young people that I have had the privilege to look after for nearly 30 years are having children of their own. Okay? But we don't know. We've talked about HIV-exposed uninfected infants and children. But for the 3rd generation, those born to perinatally infected mums and dads, what is their outcome going to be? So there are many of the same social, mental health vulnerabilities, the same experiences of stigma between both groups, but there are differences, and it's really important we recognise that. And this is data from the US, which I think is very interesting. So this looks at survival, compares perinatally infected young people and non-perinatally infected. And it looks at whether you receive what they call standard HIV care or idealized HIV care. And in their model, actually, young people with perinatally acquired HIV have the same life expectancy as those not living with HIV. But those without perinatally acquired, with non-perinatally acquired, actually have mortality significantly earlier. And that's because, as we heard from Martina, of non-communicable disease factors. It's because of lifestyle factors. However, the model did not account in the perinatal group for any premature aging, ART toxicity, ongoing inflammation, transition data. So it's just really important when we're considering long-term outcomes to actually look at the data and what is modelled. And it's very important that that data linkage continues into adult care. And what we see across the cohorts is even if you don't transition till you're 24, your data is then not linked into your 40s and 50s and 60s. This is what's happened in the UK. Virtually all of our young people are adolescents, and many of them are young adults now into their 40s. Transition is really important, and the really boring bit of it is really important. It's really important to have an advocate, a named lead, a written transition policy, and written transition paperwork. It sounds very dull. It is very dull, but we know it's what works. It's really important to have very linked up pediatric and adult services. And for me, I start talking about transition to adult care once they know, once they're 8, 9, or 10. We start talking about the future, about what you can do with HIV and where you'll be, and the fact that we have young people who are now in their 40s who have families who were in the clinic 30 years ago where they are sitting. And it's really important to have the future scope for that. I'm only here because a gentleman who talked to you yesterday about HTLV, when we were first transitioning, nearly 20 years ago, our first young people, only 1 out of the first 5 turned up. And one of the reasons they didn't turn up was they felt judged in the adult HIV service because they were 18 and the other clients were in their 40s. Okay? And so Graham said, well, one of you pediatricians has to upskill, learn some adult HIV and some adult sexual health, so that is why I'm here. I am half pediatric, half adult. Most of the time I'm very confused. But that's fine. Confusion is good, okay? But the service has evolved. It's an integrated model. We have some amazing nurse-led. We have amazing peer support workers. There's been amazing support. And we have had the privilege of working with the same young people and now seeing them have their own families, and it's really been an amazing career for me. And we never close, even in COVID, and we have, and I'll show you, very good retention rates, and that's because even if you have been out of care for 2 years, you can walk into our young person service, and we will never ask you where you have been. We will greet you with a smile, say, how lovely to see you, what's going on. There are no contracts to sign. There are no, frowns and grimaces. It's only in the afternoon. No young person service should ever be in the morning. And we try and do multidisciplinary care. And these are our outcomes. There are various posters looking at various aspects. So more than 90% have a suppressed viral load. They have excellent CD4 counts. Yes, we have some multi-drug class resistance. But what we're beginning to see in this cohort, median age 27, but some, as I said, are in their 40s, the long-term effects on multiple organ systems, including talking about solid organ transplant, given chronic lung disease. We've heard lots from Rashida Farhan's group about that in the past. However, even with very good viral suppression, compared to their HIV-negative UK peers, we still see mortality, malignancy and psychoses about 10 times that rate. The numbers are incredibly small, but it just highlights the ongoing effect of inflammation, but also the fact that many of these young people didn't start ART till they were 11. And whilst we're starting ART younger, and we hope that the next cohort will be better, actually in the real life, we know that early infant diagnosis, many kids are not starting ART still until they're 4 or 6 or 8 or 10. So that's just a window to the future. And my plea, Jess Daniels, who's one of our, Jess Glenn, sorry, one of our medical students, has done a wonderful poster looking at the very extensive, very similar to your cohorts in sub-Saharan Africa, NNRTI exposure and NNRTI resistance, and that plea for us requiring robust, long-acting regimens for adolescents who struggle with their medication, not based around NNRTIs. And this is just looking at mortality, and in our perinatal cohort, we see a change. So it used to be opportunistic infections, talking 10, 15 years ago. Then we saw young people with malignancies, unfortunately, and there's a poster again here about malignancies from the group in sub-Saharan Africa. More recently, we had 2 sudden deaths at home, both young people in their 30s, both suppressed for more than 10 years, both with CD4 counts more than 400. One was confirmed to be a pulmonary embolus, he had no other risk factors, and one was thought to probably be a cardiac arrhythmia, but cause not ascertained, no drug use. So, and I know my colleagues from the States are talking to Alison, they are beginning to see the same. So this is, the non-communicable disease, what happens, and the great importance of us looking at the role of antiretrovirals, ARV, including abacavir, whether we should be doing early statins, and really having a think about weight management, etc. from that perspective. What you do in pediatrics really matters. This is some very nice data from Ali Judd's group looking at how you exit pediatric care determines the rest of your life. So what you do as pediatricians is the biggest predictor of what happens in adult care, okay? And it's very hard for our adult colleagues to turn it around. And it's exactly the same in the Spanish cohort, how you exited pediatric care. Your CD4 count, whether you were virally suppressed at transition, and whether you had ever had an AIDS diagnosis, determined your outcomes as an adult. And we know that childhood experiences, be they adverse childhood experience, psychosocial, what happens in our early life really determines our outcomes in our 60s and 70s, and some of us are getting there. And I think there's a really great advance, and we've been talking about studies including adolescents, 12 to 17-year-old in phase 3 studies of new agents with adolescents, with the adults. It's incredibly important. And the Spanish cohort actually saw outcomes were better when they went into adult care, but that was in the early calendar years, and probably because in adult care they could access better antiretroviral agents. And this is data from the ALFI cohort, from the MRC, and actually we hear so much bad about adult care, but, I'm half an adult physician, so I take it quite personally. But actually, adults really, in HIV and sexual health, they are used to dealing with young people in sexual health, okay? And they really want to help the majority of them. And actually, in the ALFI cohort, young people preferred their adult care to their pediatric care. They wanted to be treated like a young person. They wanted to have agency. They wanted to be involved in decision-making in a truly meaningful way. So, well-managed transition can be a real positive step for a young person. It's not always negative. And this is data from the States. And actually what they showed that the boring paperwork matters, okay? But they also showed that an older age of transition was better, and they also showed that if the cohort was primarily going to one adult site, there were better outcomes. And that's because it allows our adult colleagues to develop expertise, but it also allows young people to be in a group where they can get peer support, where they can recognize, even in the waiting room, other people who look like them. Because, some of my young people have sickle cell, and they won't go to their sickle cell appointments because they do not want to look at 60-year-olds with end-stage sickle. Okay, because it's terrifying, all right? And, it's about, we're all herd animals. It's about being part of our tribe, and part of our herd is incredibly important. So I hope I've shown you the key to the future, and it's what you do in pediatrics that determines young people, how they are going to progress in adult care. And however, occasionally people surprise you, and this is a young person who Graham will recognise, who struggled. And my adult colleagues cannot believe that somebody can have a CD4 count for 10 years, get a bit of mild PCP, but otherwise be absolutely fine. She had 2 pregnancies, her babies were uninfected, and something happened at age 25, okay, where she started taking her meds. And her CD4 count, we all say if you've been immunosuppressed for a long time, you won't regain. Well, she got to 1,000. So, and if you ask her what happened, she can't tell you. But basically, she just was given the time to grow up. That period between 14 and 24 is just so important, and there's so much going on. And she's had a 3rd baby. And when we were talking about treatment interruption and cure studies, she said to me, "My babies are my cure." Poor transition and adherence is not just a factor of HIV. This is diabetic control. Okay, it goes off actually much earlier than you often think of adolescence. It goes off 10, 11. But when people, if you can support people getting to their mid-20s, things improve. adolescents deserve their own, we have something called geriatrics and we have something called neonatology, but actually in most of Europe certainly, we don't give adolescents their own space, and we absolutely should. We need to integrate mental health, sexual health, which is what we would all like, and we need to hug our adult colleagues, and we need to remove the structural barriers to care that we put up in healthcare systems. I can't change an appointment of a young person in my clinic because I don't have the code that I'm required to. How do they re-access care when they've been lost to follow-up, they really feel unwell, they don't want to be shouted at, they put it off, and how do you allow them to do that? And this is just to finish, so that the main problem with teenagers is that we were all one, but we seem to forget. The triple stigma, and that's HIV and mental health, but the third stigma is the structural stigma against adolescents, okay? Both within society. Adolescents get a bad rap for doing stuff that adults do all the time, okay? And nobody blinks an eye, okay? But also within healthcare. Healthcare is stigmatizing towards young people often. And when adolescents are thought of as, oh, they're rebellious, they won't do what we want. No, adolescents are one of the most conformist groups in society, but they are conforming to their peers and not to old people, okay? Thank you very much.